Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. It's a special day for a couple of reasons. One is it's Doctor's Day. Happy Doctor's Day to those of you who are doctors out there. Secondly, today we're holding a memorial symposium for Dr. John Murray, who led the pulmonary division at San Francisco General for many, many years, actually decades, and did as much as anyone at UCSF and really anywhere in the world to link the science to clinical practice, back to the science and back again during his very long career here. And John died of COVID. He was actually probably the first prominent US physician to die of COVID at the age of, I think, 92, living in Paris very early in 2020. So a special day for the pulmonary division here at UCSF that John Murray helped build. So our topic today is progress in obstructive lung disease, bedside to bench and back. And we'll be looking at asthma and obstructive lung disease more generally, and COPD, and try to understand better why some patients do okay and have relatively benign courses, others have really terrible courses, why some get better with certain therapies and others don't. This is sort of the crux of precision medicine. And UCSF is really one of the world leaders in trying to understand these diseases, understand their biological basis, understand what treatments work, bring those to the bedside, and then bring the insights from the bedside back to the laboratory to try to better understand what we need to do to be better at treating these diseases. And so for this Grand Rounds, we have a tag team and we have two terrific speakers. Let me introduce them to you. The first will be Prescott Woodruff. Prescott is professor of medicine and was recently named the chief of our Division of Pulmonary Critical Care, Allergy and Sleep Medicine. They have very large business cards at our UCSF Health site. His own research has really spanned the domains of bench translational and clinical research, including clinical trials. He's done really important work in asthma and COPD, has published over 200 peer-reviewed publications in all of the most prominent journals. He's an elected member of the American Society of Clinical Investigation, as well as the American Association of Physicians. Prescott got his MD at Columbia University, a residency at MGH, came here as a fellow, and lucky for us has stayed ever since. So Prescott, welcome. And then the second speaker, who will focus a little bit more on the clinical manifestations, is Monica Tang, who is newer to UCSF. She's assistant professor in our Division of Pulmonary Critical Care, Allergy and Sleep Medicine. She's actually an allergist, but who takes care of patients with a wide variety of allergic and immune-related conditions with a particular focus on asthma. And in just a few years at UCSF, I think 4 now, she's become one of our go-to clinical experts for patients with severe asthma and other immunologic conditions. Monica got her MD at Northwestern, did her residency and fellowship in allergy at Duke, and we were lucky enough to recruit her here in 2019. So Monica, welcome. I think we will turn first to Prescott and then Monica afterwards, and then we'll have some time for discussion. Prescott, welcome.
Thank you for having me. I'm going to share my screen and my slides. It'll take just a moment. And as Bob said, this will be about progress in obstructive lung disease, bench to bedside and back. I want to tell you, Bob, how grateful I am to speak at my home department Grand Rounds. This is great. I have a couple disclosures. I consult for companies that produce asthma therapeutics, but I'm going to leave all discussion of therapeutics to Monica, and that will help achieve parity. I also had a photo of John Murray, who Bob mentioned as the chief at the ZSFG for more than 2 decades, but also many, many other achievements. And one of the things I'm going to try to do in this talk is give a little historical perspective on these diseases at UCSF as I go along. We're going to begin this talk with cases. And the first 2 cases are intended to convey that asthma is a heterogeneous disease, both clinically and biologically. Here's some clinical data on 2 patients. They are very similar in certain ways. Those are listed by the black font in this slide. We have 2 65-year-old female non-smokers who are on inhaled steroids and inhaled beta agonists. But they differ in important clinical ways. Patient 1 has the lowest BMI, has fairly well preserved lung function, but requires prednisone for exacerbations on a frequent basis. whereas patient 2 has a higher BMI, low lung function, but does not have exacerbations. And this clinical heterogeneity is interesting because it could reflect biological underpinnings. And here are some biomarkers that we use in the asthma field in which these two patients differ. Serum IgE levels are elevated in patient 1, blood eosinophil counts are elevated in patient 1, and this level of exhaled nitric oxide, which is a measure used in some subspecialty practices to measure type 2 inflammation or allergic inflammation within the lung, is also elevated in patient 1, whereas they're all low in patient 2. And these biomarkers that we have in the clinic now can help us distinguish the biology underlying the clinical heterogeneity. That, I think, is fairly well known in asthma, but what is less well known is that COPD is also a heterogeneous disease and also has underlying biological heterogeneity. Here are two example patients. They are both 65 years old. They both smoked 40 pack years. They're both on inhaled steroids and inhaled long-acting bronchodilators. But the first patient, again, has a low BMI and preserved lung function and exacerbations. But the second is a patient who has a higher BMI, lower lung function, and no exacerbations. And not surprisingly, the biomarker profile that we would normally pick for asthma reflects a lot of the same biology in this older patient who was never diagnosed with asthma as a kid and who has this disease presumably because they smoked for many years. That is, patient 1 has elevated serum IgE and blood eosinophil count. We don't actually even measure exhaled nitric oxide in COPD frequently, but there's a question as to whether that might also show biology. So with that background that the clinical heterogeneity in these diseases could reflect biology, I just wanted to give you a bigger overview on why that's important. We, over the last 20 years, 30 years, have learned so much about molecular mechanisms of so many diseases, and that's super powerful because when those molecular mechanisms truly underlie the clinical, pathological, physiological features of the patient sitting in front of us, then we can come up with targeted therapies. But if the patients sitting in front of us have distinct clinical phenotypes with distinct underlying biology, those targeted therapies will fail to work in a significant percentage of patients. And that is the crux of precision medicine, and that's essentially what's played out in the world of new treatments for severe asthma. When I started showing this slide, this was all kind of theoretical, but it's really turned out to be how the field has progressed. I was lucky. I landed at UCSF in 1998, and I wanted to go from bedside to bench. And there was a group here that was already using methods and applying them to patients to understand airway disease in our UCSF Airway Clinical Research Center. They were my mentors, Homer Boucher, John Fahey, and Steve Lazarus. And through working with them over the years, we have been able to make inferences from bedside to bench and back. And in asthma, the first inference that was made on examination of induced sputum from these patients. This was done in the 80s, and it turned into a test for PCP in the HIV epidemic. But it started out as induced sputum studies in asthma. And what John Fahey and Homer found is that a lot of patients have the expected eosinophils if you do a cytological examination of an induced sputum. These are the red cells here. But a lot of patients do not. And they still have an asthma-like condition that for all the world, sitting in front of you, would make them similar to the other patient. And this turned out to be really biologically important and then clinically important, as I'll show you. Now, sputum eosinophils are a cell that we're all familiar with, but more generally, they're an indicator, an arm of an archetypical adaptive immune pathway. There are at least 4 archetypical adaptive immune pathways that the body uses for host defense. These are pathways that are typically organized by T cells, either Th1, Th2, Th17 pathways, et cetera. In the case of asthma and allergic disease, we typically think of it as diseases caused by aberrant T2 inflammation or Th2 inflammation, as indicated here. These are describing T helper type 2 cells that organize the inflammation. They produce cytokines particularly IL-4 and 13, but also IL-5 that I'll talk about. And they're designed to combat extracellular parasites and produce immunoglobulin E, or IgE, all of which are important in expelling parasites. And this, because of research done, for example, by Rich Loxley in our Division of Infectious Diseases, has really been established as the major archetypical adaptive immune pathway that underlies allergic disease. Now, if we were to schematize what happens in type 2 inflammation in the airway and simplify it, it would look something like this. The airway epithelium, which lines the airways, responds to stimuli, maybe allergens or viruses, and produces TSLP, as well as a couple of other cytokines. They induce T cells and other cells to produce those cytokines I showed you, 4, 5, and 13. And that those cytokines exert the effects. They induce IgE, they recruit and sustain eosinophils. They actually can cause almost all the features of asthma that we see in a human. And this was worked out in mice by Rich Loxley and others, and was already, when I arrived in 1999 and 2000, understood as probably the molecular basis for asthma. So when I landed in the ACRC, we wanted to understand whether this was true in people too. And so we did bronchoscopy studies, and these are what I call bedside samples. We actually asked volunteers in the community to come in who had asthma, who didn't. We did bronchoscopy and placed a brush in the airways, and we started to use new methods called microarrays to study gene expression. We found that 3 genes were very highly expressed in asthmatics, and that these were all induced by IL-13 in vitro as well. And so we thought, look, we've proven it. The T2 pathway and IL-13 are important in asthma in humans. And so here is the actual data of very high expression of, say, periostin in asthma compared to healthy controls. It took us several months, but we realized something even more important, that this was true, but not in all patients with asthma. And in fact, there's a group in whom periostin is high and a group in whom it was low, and we started to wonder whether that was important. And it turns out that the same people who were high for periostin were high for CLICA1, and if you organize these gene expression data in a heat map, where the genes are in rows, you can see that the red or high patients all clustered together. They're high for all 3 genes. And that was half of our asthmatics. Whereas the other half were low for these T2 marker genes and indistinguishable from healthy controls, denoted here by H's. And we started to wonder whether what we had wasn't just evidence that asthma was a T2 high disease, but that there were actually 2 types of asthma, Th2 high and low. And interestingly, in this original study, we had done a placebo-controlled clinical trial embedded in it. And this was a trial of inhaled steroids given over 8 weeks in all those people who we had just characterized as T2 high or low with brushings. We also did a placebo control arm. And what we found is the placebo control arm in black had no improvements in lung function, FEV1 here, as you'd expect during the 8-week treatment period. But people who were T2 high had improvements in FEV1 during the treatment period that went away when treatment was stopped. And people who were T2 low had no improvement in lung function, despite treatment with the bona fide established therapy for asthma. And this kind of nailed it for us, that there really was a clinically important T2 high, low subsets of asthma, and that we couldn't distinguish them when they were sitting in front of us. So this concept led us to wonder, well, what are the other features of T2 high asthma? Can we delineate them? What does it teach us about biology? And there were many things that we studied using bronchoscopic samples from the bedside. The first thing was just to be sure that we were linking this molecular signature to the cellular signature I showed you at the beginning. That is, does T2 high asthma have elevated eosinophils? And it does. This is eosinophils in the bronchoalveolar lavage fluid, whereas the T2 low asthmatics do not. We studied other cells in the airway. We asked whether mast cells, which are a resident lung cell and innate cell that produce leukotriene mediators, we asked whether they differed between T2 high and low asthma. And we found that there were intraepithelial mast cells in asthma, but only in T2 high asthma. And for aficionados, we found that they express a very specific set of proteases, tryptase and carboxypeptidase, but not chymase, and actually kind of a new and different type of mast cell than what exists in other clinical settings. And so there's a very specific biology associated with T2 high asthma from an inflammatory standpoint. About that time, people were really interested in the pathology of asthma too, in part because the structural changes that occur with longstanding asthma could lead to persistent and severe disease. And so we took biopsies from patients who we were characterizing as T2 high and low asthma. You can tell this is not easy to do. We're getting brushings, biopsies from patients. And so the bedside part of this is terribly important, well-controlled, and a fundamental part of the clinical science. I'll show you two of the things we found from the biopsies. One is that T2 high asthma is the subset of asthma that has fibrosis. This is a trichrome stain, and this collagen deposited below the epithelium is the fibrosis, and you can measure the thickness of it. The reason that's important is because remodeling of the lung, airway remodeling, is thought to underlie severe and persistent disease. And we found that this was truly thicker, and the correlate of the thickening of the airway wall in our diagrams here, but only in T2 high asthma, not in T2 low asthma. Another structural feature that John Fahy and Eleanor Dunican showed is that T2 high asthma has mucus plugging, and that, again, is associated with severe asthma. Here are CT scans, and all this work was done with CT scans. One would not normally pay too much attention to the luminal filling in this CT scan. You might just say it's present, but they actually counted them at quantitative CT scans from the Severe Asthma Research Program and found that severe asthma is indeed associated with mucus within the airway and with 3 or more plugs plugged, but that this was only present in T2 high asthma. And so through these studies and many more, the work that John and I and a lot of others did really elucidated the molecular phenotype of T2 high asthma, where these patients, which constitute 50 or 60% of asthma at least, have airway eosinophilia, subepithelial fibrosis, increased mucin in the airways that impairs airflow. I didn't show you this, but a different type of mucin gene expression, increased numbers of mast cells, different proteases, a whole host of inflammatory and structural differences. And that our hypothesis would be that this is caused by IL-13, IL-4, and IL-5, and that if you could block these cytokines, the disease would get better. This also leaves the conundrum of T2 low asthma that has few of these features or no of these features, but is indistinguishable when sitting in your clinic office, and therefore a really important clinical need that is mostly unresolved. Now, this is a simple story. We've got 2 types of patients. It's clean, cut and dried, but the truth is actually a little more complicated. If you look under the hood and spend time looking at the data, T2 high asthma actually exists on a spectrum. And so I don't want to oversimplify it for you. There are some patients in this figure, for example, that have very high levels of expression of those genes I showed, or very high eosinophil levels. And they have very high T2 asthma with more obstruction remodeling, et cetera. And there are people in the middle, and there may be some people who vacillate. And then there are people who are always T2 low. And that's truly the biology after 2 decades now of doing this work. But labeling patients as T2 high and low is useful for clinical care. And it helps us decide when to make this treatment decision versus that treatment decision. So we still talk about T2 high and low asthma. Now, to use this information clinically, we need to have biomarkers of type 2 inflammation that we can use in the clinic. And IL-13 and the other T2 cytokines have a host of effects that could yield biomarkers. In fact, John and I spent I don't know, 5 to 10 years working on a novel biomarker. It never really made it to the clinic. It would have been, I suppose, valuable because the available biomarkers all have their weaknesses. One is sputum eosinophils that I showed you. Another is blood eosinophils, which are a dim reflection of what's happening in the lung, but potentially useful. Another is this exhaled nitric oxide level. And then serum IgE levels, which you'd think would be good, but don't distinguish T2 high and low that well. Nonetheless, these are the available biomarkers, the biomarkers I showed you in the cases at the beginning, and have been used in the development of drugs as, and ended up on drug labels as the biological features that you could use to distinguish your patient. They also are now in the asthma treatment guidelines if you look at them and you're trying to decide what to do with an asthma patient or a severe asthma patient. So this begs one other question. What about those T2 low patients? What can we determine about them to advance care? I'll show you two really quick stories. One gets back to this idea that there are very classic archetypical adaptive immune pathways that are designed for host defense that can go awry in inflammatory disease. And I talked about Th2 as one of those pathways, and of course there's another one, the Th1 or T1 inflammatory pathway. In this pathway, interferons are the predominant cytokine produced by Th1 cells and in an attempt to combat intracellular pathogens. Nirav Bhakta, who some of you will know from our ICU and clinics, is part of our ACRC, and he spent some time trying to understand whether there's a T1 or interferon high asthma subgroup. And so he went back to the brushings that we did and got some new brushings at the bedside from our patients. And he went back to the gene expression data and asked, are interferon signature genes present and elevated in asthma? The answer was yes. And then are those interferon genes only in a subset of patients? And here's the same sort of heat map figure. Here are the interferon-related genes in rows, the patients in columns, the asthmatics in red, the healthiest in black. And it does show that asthma differs from health, but that there are some asthmatics who are high for those interferon genes and some who are low. And that turns out to be a potentially interferon high subgroup, and several other groups around the country are now studying this. Although it's more difficult to treat, you might have to use something like a JAK inhibitor in this instance, and something less targeted perhaps that we'd really like. There's the high and the low for interferon. Another T2 low pathway that we've been studying is going to be familiar to all the primary care physicians. You will know that there's a subgroup of patients with asthma in your clinics who have metabolic syndrome. By that I mean some combination of obesity, hypertension, and insulin resistance. These patients have a variety of systemic diseases and oftentimes have asthma. It turns out that IL-6 in the plasma and serum and CRP are good markers of this type of inflammation associated with metabolic syndrome. And I won't go through all the data, but Michael Peters, who was in that photo on the last slide, in the pulmonary division, has spent a lot of time showing that indeed elevated IL-6, CRP, obesity, hypertension, and diabetes define a subset of more severe asthma that can be layered on to type 2 inflammation to make your asthma worse. And here his idea is distinct from aeroallergens causing inflammation within the lung. The idea here is that inflammation outside the lung, systemic inflammation, can affect the lung indirectly. And so this also could be amenable to targeted treatment. Now, very quickly then, we've learned all this about asthma. What about COPD? COPD is also a heterogeneous airway disease. And one of the ways we could look at asthma and COPD is that maybe they have related underlying biology. And maybe the adaptive pathways that play out in one disease are the same as another. So we typically think of COPD as having very distinct phenotypes, a chronic bronchitis and emphysema phenotype. The blue bloater and pink puffer in the Netter diagrams. But there's a pretty well-recognized clinical subset that is kind of an asthma COPD overlap that people suspect have shared underlying biology. And can we use what we learned in asthma and apply them to COPD patients to understand the molecular basis for this? Stephanie Christensen, another faculty member in pulmonary in the ACRC, has spent a lot of time working on this. And the really short story here in one slide is that Stephanie took patients who were volunteering to have bronchoscopy. And in this instance, this was data from a lung cancer screening study that was done at another institution where they did brushings and gene expression studies and asked, can we use markers of type 2 inflammation like the CLIC-01 and periostin I showed you here in rows and organize these smokers who are at risk for lung cancer in columns according to the level of T2 associated genes? And the answer is yes, there is a T2 high group. And there's also a T2 low group. Now the size of this group is smaller in smokers. It's more like 20% of the population, not 50 to 60%. But it's interesting because this group is more likely to have COPD, as denoted by the purple bars here. And it's also interesting that these patients were classified as having asthma or not clinically. And they were not more likely to have asthma by a clinical physician judgment. This T2 inflammatory signature was occult to the clinician and was really only detectable by doing the measurement. This, she went on to show that this is the group that responds to inhaled steroids, both with improvements in eosinophils in the tissue, but in lung function. And so this provided some initial data that all of the research that was going into molecular pathways and maybe blocking molecular pathways that was going on in asthma and severe asthma could potentially be useful in COPD as well. So that was a lot of biology. What we'd like to do is take the biology from the patient, bring it to the bench, understand how those cells and molecules work together, then understand how to interfere with them, and then translate that back to the bedside. And for this part, I'm going to pass the baton to Monica Tang.
Hello. Okay, let me share my screen. Okay, I think it's working. All right. So yes, so we wanted to bring this, next take our journey from how this bench understanding, bringing it back to the bedside, has really allowed us to identify and characterize these patients better. So reviewing those asthma patients from the start of the presentation, patient 1 who was prone to exacerbations had the elevated IgE, blood eosinophils, exhaled nitric oxide level, they're T2 high. And patient 2 who was obese, didn't have the elevated IgE, blood eosinophils, or exhaled nitric oxide, is T2 low. And in that one COPD, that patient 1 who had the now 40-pack year smoking history and no prior diagnosis of asthma, but had elevated IgE and blood eosinophils, has some evidence of T2 high. And the most gratifying part of identifying this for patients is that this has allowed us to target therapies in a precision medicine approach. So Prescott reviewed this slide earlier, highlighting some of the critical mediators in T2 high disease. And part of the reason we focused on this is because there are now 6 biologics approved in severe asthma that target these mediators. So omalizumab or Xolair targets IgE. Mepolizumab, breslizumab, and benralizumab, which are Nucala, Sinqair, and Fasenra, target IL-5, which is this eosinophil survival signal. Dupilumab targets IL-4 and IL-13. It's also known as Dupixent. And then tezepelumab or Tezspire is our newest one, which targets TSLP. And there are no head-to-head direct comparisons between these biologics. So this table has a lot of data. It's meant to summarize many of the different trials of these therapies. And generally what the studies have demonstrated is that the biologics can make a huge difference for the right patient. So on average, they have an approximately 50% reduction in exacerbations and an 100 ml mean improvement in FEV1, a significant reduction in patients who were requiring chronic daily steroids to be able to come off of them or reduce them, and then improvement in asthma symptom scores, although they didn't always meet the minimal clinically important difference in the study, so that outcome wasn't as well achieved. Choosing which biologic for the right patient depends a lot on many different factors. It depends on what you want to target, whether they have other comorbid diseases that we're also trying to treat, how frequently they want to get, since these all have different dosing schedules, whether patients will do injections at home or in the clinic, and then, of course, unfortunately, sometimes potentially coverage. Anecdotally, I can tell you taking care of these patients is incredibly rewarding work. This has completely revolutionized how we take care of some patients with severe asthma who have these types of asthma. They are able to treat their asthma in ways they never have before. It is life-changing for them that they no longer are having so many exacerbations, so many symptoms, so much need for these therapies that were not as targeted and had a lot of side effects for them. And so they think you're the best doctor in the world because you're able to help them in ways that we previously hadn't been able to. As for COPD, there was a very timely press release from March 23rd about Dupixent, that's that anti-IL-4, IL-13 therapy, that demonstrated that there was significant reduction in COPD exacerbations in some patients. And in fact, when I went back and looked at clinicaltrials.gov, there's actually been studies for many of the T2 biologics that have already been approved in severe asthma to be studied in COPD as well. So this press release was for this first trial for dupilumab that I have listed, Boreas, which preliminarily has reported decreased exacerbations and improved lung function. And there is now this other NOTICE trial that's currently recruiting to replicate those findings. Interestingly, the therapies targeting IL-5, which here are mepolizumab and benralizumab, haven't consistently demonstrated decreased exacerbations so far. So Metrix and Matrio were 2 phase 3 trials that were pooled together in an analysis listed here. And there was some evidence of decreased exacerbations in the eosinophilic phenotype in Metrix, but interestingly, the primary endpoint wasn't completely met in Metreo. Now, the higher people's eosinophils were, the better they did. And so they are refining sort of their target population and redoing now a study, Matinee, that's recruiting currently. Benralizumab similarly had 2 phase 3 trials, Galathea and Terra Nova, that were pooled together for analysis, and they also didn't decrease exacerbations significantly. There were, again, though, some differences in sort of the target population and dosing, and so they are also refining their study, and there is a currently recruiting Resolute trial going on. And finally, that newest one we were talking about, the anti-TSLP therapy, tezepelumab, there is an active study going on now to see if it can be beneficial in COPD. As we talked about, T2 high has been our inflammatory pathway that we've had the most success in so far. So T2 low, there are no currently approved medications for targeting specifically T2 low asthma or COPD. I did want to highlight this study, the PRECISE study, which is a NIH, NHLBI study that's called the Precision Medicine in Severe and/or Exacerbation-Prone Asthma. It's an adaptive design study that's to evaluate novel interventions in biomarker-defined subgroups of severe asthma. So this trial uses a crossover design with multiple periods where the subjects can actually be treated with multiple interventions, and the 5 interventions are being studied are here. And they do include several therapies targeting potentially these T2 low patients. You notice here that IL-6, there's an anti-IL-6 therapy called clazakizumab that's specifically trying to target obesity, metabolic dysfunction patients. There's this KIT receptor inhibitor, imatinib, that is being tried in a T2 low population. There's medium chain triglycerides, trying to do nutritional ketosis that's been target like high arginine metabolic asthma. So there are new therapies that are being tried in these populations, which will be very helpful for these patients. UCSF is actually a site that's currently enrolling for the PRECISE study. I have the link there listed below. So if you or anybody you know is interested in participating or learning more about the study, please feel free to contact me or reach out. So in conclusion, we wanted to walk you through our journey, which was that obstructive lung disease is heterogeneous. This heterogeneity reflects archetypical biological pathways like T2 inflammation. Targeted therapies have revolutionized severe asthma care and hold promise for COPD. And a bedside to bench and back approach by physician scientists has really made revolutions like this possible. And we would be remiss if we didn't acknowledge the many people involved at the bedside and at the bench for this work, including the many members of the UCSF Airway Clinical Research Center and the ongoing asthma and COPD studies, as well as the members of the UCSF Allergy Immunology, Asthma, and Severe COPD clinics. And then the generous support from funding sponsors, including the NHLBI, NIH, and the Sandler Asthma Basic Research Center. We would be happy to take any questions.
Great, thank you so much, Prescott. Why don't you come back on? And Monica, if you take the slides down, that would be great. Thank you, terrific. Plenty of time. If anybody has questions, please put them in the Q&A box, and I will monitor them. Let me start with a question from Paul Fitzgerald. GERD is frequently found in asthma. Is GERD with aspiration a significant cause or exacerbator for asthma? Either one of you jump in.
I'll defer to Monica on this one.
Yeah, as someone who sees patients in clinic, it often is. That is definitely still the case that we see there are a lot of comorbid conditions in asthma or COPD and lung disease in general, and that those comorbid conditions, whether they're sinusitis, sending stuff down into the airways, reflux, sending stuff up from below, can be affecting people's lung disease. And so identifying that is a key component to it. And not just targeting one type of thing. As always, often disease states are multifactorial, so it is definitely a piece to the puzzle.
Yeah, can I add? The clinical answer is just as you said, which is that you really have to consider treating GERD aggressively if you're going to get control of asthma or severe asthma. But the biology is potentially super interesting, which is that we didn't even talk about neural pathways and how sympathetic and parasympathetic and other neural pathways are important in asthma, and how stimulating the foregut in another way could synergistically influence a disease in another organ.
Great. Thank you both. It's a terrific talk. Let me sort of pull back a little bit to the perspective of a generalist, which I am. I'm seeing someone in my practice who's got what looks like mild to moderate asthma. They haven't had many exacerbations. They seem to be well controlled on medicines they've been on for a decade. They're on let's say, a long-term beta agonist, and they use an inhaled steroid, and they're kind of doing okay. How do I know that they need to see you? How do I know that they need one of these fancy and I'm sure quite expensive MABs? And if they do, you've made the case that the sort of easily accessible biomarkers aren't all that good. At least that was the case that Prescott was making. And then, Monica, it seemed like some of the clinical trials were hinging on blood EOs, which I think he told me 20 minutes ago aren't all that reliable. So why don't you first take the use case of a patient who's just not doing all that badly and is reading about all this fancy stuff out there and is trying to figure out, is there something better out there? Do I stick with the tried and true?
Well, I'll start with that. So I think that, as always, like Prescott was saying, it's a spectrum. So at this point, if people are super well controlled, then potentially their current therapies are okay for them. Now, there have been advances beyond actually biologics specifically that might be helpful for their asthma or COPD. And so if you have any questions, I would say always feel free to refer to an allergist or an asthma or pulmonology doctor, because there are constantly advances coming down the pipeline. In terms of helping decide, though, I do think we have for a long time accepted things in asthma that honestly are not theoretically necessarily super acceptable for patients. Currently, most patients who have an asthma exacerbation or who have asthma defined by the CDC have at least an exacerbation per year. And we say that's okay. We say that's controlled asthma, but that's people who are missing work, missing school, having to go to the hospital, having to pay these healthcare costs. And so I think there is some idea, if these were inexpensive, not medicines that have side effects, potentially, yeah, in the future, we could argue theoretically, even patients who are doing well on current therapy, there are worse side effects to those medicines than potentially the ones that we would be using. At this point, though, that isn't the case, I would say. And so for right now, if people are doing well, then I think that I generally will say, you're doing really well, continue on your current therapy. If it gets worse, then we have more options. I do think to recognize that people can change that's one of the key characteristics of asthma, is that you will change over time. So often we are stepping up and stepping down therapy. And so that patients should recognize if they are not doing well, even though they had been doing well, a month or a year ago, that is a time to come back, because there are real new therapies that could potentially really, really help them. And it's very variable. I think we talked about some different types of patients. So like, for an example, I see some patients who are actually totally completely fine and then just exacerbate. So they have no symptoms. They can run marathons, but they exacerbate every single year, multiple times a year.
Mm-hmm.
Does that patient need a biologic? Potentially, yeah. Exacerbation prone asthma, where they have so many side effects, is potentially an issue. So I would argue that patient is justifiable even more than somebody else who maybe is on more the cusp. So it does depend, and does take teasing apart exactly what's going on with each patient to determine whether these types of therapies are appropriate.
And then just in clinical use, and maybe have Prescott weigh in on this as well, it sounds like you're looking at a whole bunch of markers to try to figure out what might be the best therapy. But again, Prescott said that most of them, at least the ones that don't involve sticking a big tube down into your lungs, aren't all that helpful. So how do you clinically reconcile that? And then I'll come back to Prescott and see if he wants to go back on anything he said earlier in the talk.
Yeah, it's interesting. And as an allergy immunologist, I get to always come back to, I try to understand the pathway that I'm trying to block when I think about each person. So I try to phenotype them clinically to see if they try to somewhat fit into a different category. So say somebody, as someone who has asthma, got a new dog and now their asthma is terrible. That sounds like very allergy driven. So then an anti-allergy therapy like Xolair, anti-IgE may be the most appropriate. Mm-hmm. Similarly, if somebody, I referenced this before, but somebody who has many atopic diseases, so eczema, eosinophilic esophagitis, who has asthma and nasal polyps, actually Dupixent is approved for all of those. So I might be able to hit a little bit of all of it, even if I'm approving it for severe asthma alone. Mm-hmm. So sometimes it's some combination of that. Exactly targeting which biologic is going to be the best for each patient is actually ongoing study. We need better biomarkers.
It sounds like your phenotypic piece, you sort of the history, is a more important thing right now than any particular biomarker you can get from a lab or from an X-ray.
Yes, to a certain extent. So yes, definitely. There are certain specific indications that you do have to hit to get insurance coverage based on the trials. So for example, to get an IgE therapy, your IgE has to be between 330 to 700, and you have to have evidence of a perennial allergen. For the eosinophilic drugs, you have to have at least probably an absolute eosinophil count greater than 150 and beyond an oral corticosteroid. So there are certain things that we kind of already know to hint us. Mm-hmm. But beyond, once you hit that criteria, what you do with somebody, is very, at this point, based on your clinical suspicion.
Prescott, anything you want to add?
Well, I would totally love Monica's response. I would say the way I practice, say, in the intensive care unit is that I'm going to look to guidelines to have summarized the known literature and try to simplify it for a simple country doctor like me. And the guidelines now do incorporate some of these biomarkers in understanding whether you think your patient has T2 high asthma. So they incorporate blood eosinophils and exhaled nitric oxide. But they don't necessarily, they're still okay.
Mm-hmm.
They don't necessarily include the IgE level. And that's just not that specific, it turns out. They include allergen-driven symptoms, just like Monica said. And they also weight childhood onset. And so, when I go look it up, that's what I see. And none of those are perfect, but those are all, might push you in this direction. And then the other thing that Monica alluded to in her talk was that there are these classic non-pulmonary conditions which accompany T2 asthma. Sinus polyps, for one thing, as an example. And if you have one of those, or allergic dermatitis, then you might give these drugs because not only are they good for this, but they're good for those, and that might push you in that direction.
And I tend to think of asthma, probably incorrectly, as this dynamic disease that your airways are spasming. In addition, I understand there's inflammation and other stuff that's happening. Is there any role for kind of therapeutic trials in that you would think that the response to something might be fairly prompt and that you could measure it in terms of peak flows or those sort of things? Does that play a role in your thinking about how you're going to manage a patient?
Absolutely. Yeah. So right now, because our biomarkers are there, but not perfect, essentially that's what I tell people. We go on a therapy, I'm guessing it's going to work based on your biomarkers and your clinical phenotype, and we try it. I expect something, usually for most people, it's immediate. Literally, I have patients with nasal polyps who have never breathed in their entire life through their nose. They call me and they're like, a week later, I could already breathe through my nose and I could smell again. And it is life-changing, like I said, for them. So sometimes it's very rapid. Sometimes it does take 3 or even 6 months. And if after 6 months, someone really isn't responding to in any way, I'm like, we targeted the wrong thing. This wasn't what it was driving your inflammation. We guessed our best we could with the biomarkers we had, but it wasn't good enough. So that's been my experience.
Got it. Question from somebody whose Zoom name is Babaji. I don't know who that is. Any therapeutic measures that could slow the progression of airway obstructive disease? Interesting question. What comes to mind is rheumatoid arthritis and disease, when the paradigm shifted to just treating the symptoms to actually biologics or other things that could actually slow progression. So maybe Prescott, what's your thoughts about that?
Sure. The experience with rheumatoid arthritis and how it actually changes the progression of the disease has inspired parallel thinking in asthma, but to date it has not actually shown the parallel. That is, most asthma therapeutics, whether it's inhaled steroids or these medications, so far look like they work when you're on them, and you get off of them, and they don't. You can go back to the disease severity and activity that you previously had. There are no truly disease-modifying therapies yet. I was part of I'm on a review paper, where we got experts together. I was one of the quote experts, and we were asked, well, how would you even define progression? And so we defined it in several ways because companies want to. How would you define activity? And how would you define remission? Because companies want to use those definitions in their next phase of clinical trials. But I haven't seen anything yet that's convincing.
Okay. Kelsey Ige, maybe IgE.
She's one of our allergy fellows.
That's a play on words. No?
That's her.
That is her. Okay, great. In the study that looked at dupilumab in COPD patients, did the cohort have evidence of Th2 inflammation, i.e. COPD asthma overlap, or are biologics being looked at in COPD without evidence of Th2 inflammation?
Yeah, that's a good question, Kelsey. So I can start. So the study where they looked at the dupilumab and the COPD, where they just published it, is actually, or just put out the press release, has actually not been published yet. So this is all based on a press release. So we'll have to see what the actual study outcomes are when it finally gets published, to say for sure. Of the ones that have already previously been published, they design the trials sometimes depending differently. Sometimes they take everybody with COPD, but then pre-specify that they're going to stratify them by eosinophil measures, for example, for those IL-5 inhibitors. And so they're hoping to guess it. And then sometimes they just enroll people with a certain eosinophil count. So that's part of what they're wondering, is if we didn't target the right exact patients, because that is what we have found previously. When we use mepolizumab for everybody with asthma, it actually didn't work either. You have to target the people whose eosinophils are on in order for it to work. So there is some of that they do have to differentiate exactly how much T2 inflammation in a COPD, for example, would be necessary for you to consider that person like T2 high.
Mm-hmm. Great. Thomas Burns asks, how much steroid sparing is expected with some of these newer agents?
I'll pass it over to Monica again.
It depends on the patient, of course, but for many of my patients, I can completely get them off of their steroids.
Yeah.
Including inhaled, or you just talk about systemic steroids when you talk about steroids?
Oh yeah, the inhaled steroids are an interesting question. That is a TBD. We haven't determined yet. Many of my patients do stop taking their inhaled steroids because they find they don't need it anymore. Although classically, in many of the studies, clinical trials, they had them continue all their therapy, obviously, throughout the trial. So that's to be determined whether it would be safe or we should be stopping their inhaled steroids. Their systemic steroids, yeah, I can. There are, of course, exceptions, but honestly, it's exceptions to the rule. Nearly everyone I can get completely off of their chronic prednisone that they had been taking for years, which is phenomenal.
Okay.
And one of the drugs actually did, as part of its development program, a study of steroid withdrawal, not just oral steroids, but reducing the dose of inhaled steroids, and it worked. It was very effective at reducing inhaled steroid dosing, and it's actually on the label. So these drugs do work for that purpose.
Prescott, have you come to believe that, compared to what you thought 10 or 20 years ago, that COPD and asthma are sort of the same-ish thing and a part of a spectrum, or are very, very different biologic phenomena?
Well, in many ways, they're different. The COPD is in part a disease of injury, of emphysema, of structural breakdown of the lung. And that's very difficult to manage. But the surprising thing is that in some other features, especially the features having to do with the airway disease, the kind of blue bloater as opposed to the pink puffer, that some of those features are reproducibly seen in asthma and COPD. T2 inflammation in a subset. It turns out that John Fahey and his group have shown mucus plugging in a subset. And you could probably find others. We're interested, for example, in endoplasmic reticulum stress, ER stress, and we see it in both diseases. And so the emphysema is very different. Mm-hmm. The airway disease has some shared features.
Mm-hmm. Anything you want to add, Monica? Okay. Anil Gemeyer, sorry if I'm mispronouncing it. What are your thoughts on chitinase-like proteins, YKL40, as a biomarker in severe asthma? It's maybe an insider question.
It's kind of an insider question, but it's super interesting. There are two chitinase stories that I consider slightly distinct. One is a story that chitins, which are sugar moieties, carbohydrates that are on insect, shells, are widely available in the environment, that we get exposed to them all the time, and they exacerbate allergic inflammation. And Rich Loxley has shown this in mice again. And we've done some translational work in that, so that they can drive type 2 inflammation. There's another story which your questioner was referring to, which is another chitinase that's present in the blood, which maybe evolutionary had the function of breaking down chitins, but is actually produced by macrophages and probably not part of T2 inflammatory pathway, but a distinct and separate pathway of inflammation that could be linked to T2 low or a non-T2 pathway of inflammation. And that may be true. I haven't put it in my slides in part because I don't know that the follow-up studies have really demonstrated it, but there was a paper, 15 years ago now showing YKL-40, this serum chitinase is associated with severe asthma. And I do believe it drives inflammation, just maybe not T2 inflammation.
Great. I think that's the last question I got. I'm getting toward the end. I want to get a free consult. I can avoid my copay. I never had any problem with asthma till about 20-ish years ago. So I was about 40, and then every winter would get a bad upper respiratory infection and then start wheezing, sometimes moderately, severely. First of all, it hasn't happened in 3 or 4 years. I assume that has something to do with my mask wearing. So I want to ask about that and whether you're seeing changes in the kinds of patients you're seeing and the frequency as people have worn masks, and whether you're seeing changes back as people ditch them. But the second is sort of the therapy of someone with episodic asthma. So I was fine 11 months a year. This 1 month I was fairly, sometimes quite disabled by it. But I treated it usually with some combination of inhaled steroids, beta agonists, and an antibiotic that I have no idea whether I needed or not, but seemed to work. Does the treatment of somebody like that with episodic asthma who's fine 11 months a year, is that changed in your mind? And then also talk a little bit about the mask wearing, what you've seen over the last several years.
I'll defer to Monica.
So yeah, yes. The short answer, the summary answer is yes to both of those. Okay. So one is that with mask wearing and over the course of the last 4 years, we have actually seen that asthma exacerbations have gone down. And in large part, we think that is because doing the shelter in place, washing your hands, not just the mask wearing, honestly, but all of those components have probably significantly reduced virally induced exacerbations for people, which is great. Now, hopefully we don't have to go to such draconian measures to potentially make people never have an asthma exacerbation, but keeping these practices in mind will be really great going forward for people who have these virally triggered asthma flares, so that they know there are things you can do, especially in the winter, to hopefully help prevent them from happening. Mm-hmm. Now, in terms of episodic treatment,
before you get to the episodic treatment, while I'm thinking of it, the impact of COVID on asthma and or COPD, what have you seen in your practice? Because by now, probably 80 or 90% of folks have had COVID, and so what has it done to the trajectory, and has it caused asthma in some people?
So so both of those. So in terms of what happens to people who have pre-existing asthma, and I see less COPD, so I might not address that as much, but in terms of the asthma specifically, there was a lot of concern initially because many viruses and even coronaviruses can trigger people's viral exacerbations. And for the large part, it hasn't seemed like everybody who has asthma necessarily exacerbates, which is great, because on the other ones like rhinovirus and influenza, pretty typically almost always exacerbate many people. So it was nice to see that aspect of it. However, the older you are, the more severe you are, some of those more comorbidities, there is still some concern. So definitely tell people who have especially more severe or uncontrolled asthma, you are still at increased risk for severe asthma or severe COVID infection. So keep in mind that to try to minimize your risk. And then in terms of causing, I have seen patients who previously didn't have a history of asthma, who after COVID, and this is a question, is this long COVID in some sense, who have now developed an asthma-like phenotype afterwards, which we have historically also seen after other viral illnesses. So that I've seen and we'll continue to understand a bit better. And then in terms of the folks with episodic asthma? Yeah, so episodic asthma has actually completely changed. Even in the sort of newest, everyone remembers the really old STEP guidelines that you learned. It's actually been updated in 2020. And so now there's a lot more support for intermittent treatment. So the GINA guidelines, the Global Initiative for Asthma, actually updates every single year, and they've actually completely converted over for intermittent therapy. Instead of using albuterol, to use an inhaled corticosteroid and a long-acting beta agonist, similar to what you're doing, because it seems to help people when they're exacerbating, potentially A, control their symptoms, and then B, prevent the need for prednisone and hospitalization and all the poor asthma outcomes that happen. And for certain patient populations or certain patients, it does also, there is non-inferiority to taking a steroid every single day or taking a steroid long-acting beta agonist, like when you have exacerbations. And if you do well with that and don't need it all the time, then that certainly can be a way to control asthma. So what you're doing actually has now literature to support your practices. The antibiotics maybe.
Yeah, the antibiotics, yeah.
That one, there is not as much support for that one. Although I will say that there are some people who I have found, particularly the antibiotics. I don't know which one specifically, azithromycin particularly has a little bit more data behind it. So there is some data, but I think that one's always hard because you have to target, as always with any of this, you have to target the right person. So I don't think every single person with asthma azithromycin helps with, and so potentially it is a targeting issue that we need to find the right patients, and that's why sometimes the study shows some benefit and sometimes they don't.
Right.
So I would try the Symbicort.
I just saved $20 a copay. Thank you. Thank you both. Really terrific, instructive, and one of the lovely things about being where we are is the interplay between the research and the clinical and the research, and I think you two exemplify that beautifully. So thank you for that and for the work you do. Be well.